In this video, I'm going to talk about antepartum hemorrhage. So how would we define antepartum hemorrhage? It is basically vaginal bleeding from 20 weeks of gestational age to term. If the bleeding occurs anywhere in between this, we call it antepartum hemorrhage. And what could be the differentials? It could be either bloody show, which is the physiological etiology in third trimester. So if it is happening in third trimester, there are cervical changes, there is early stages of dilation, then it must be bloody show. But if it's not that, then it could be placenta previa, placental abruption, which is the most common pathological etiology in third trimester. So in third trimester, the most common physiological etiology is bloody show, but most common pathological etiology is placental abruption. Then we have Vasa previa, cervical lesions, which could be cervicitis, polyp, ectropion, cervical cancers. These might cause bleeding too. Uterine rupture. Uterine rupture is also very life-threatening for the fetus, especially. Other, bleeding from bowel or bladder or abnormal coagulation. All right. So for this, I'm gonna just explain this table, and then I'm gonna move forward for the question in UWorld. So we have two things: placenta previa, abruption placenta. What happens is placenta previa, the placenta is located abnormally in the uterus. We say if this is uterus, then placenta inside it could be either located directly on the internal os, or it could be located on one of the side but pretty much overlapping the internal cervical os. So partially or completely covering the internal cervical os. But what happens in abruption placenta? Premature separation of a normally implanted placenta after 20 weeks gestation. So the placenta might have been attached over here, it's inserted here. But after 20 weeks of gestation, especially in the third trimester, this placenta prematurely separates from the wall. This starts to bleed. The premature separation would lead to bleeding. And we'll further read two types of it. But abruption placenta would be very painful, and it usually is painful. But the placenta previa right here, if it's lying over here, then it could be painless. Okay? Risk factors for placenta previa: previous placenta previa, multiparity, increased maternal age, multiple gestation, uterine tumor, uterine scar due to previous abortion. So previous abortion, okay, because of many reasons, but it might include previous abortion too. So if you think that here's the uterus, because of the previous scar right here of cesarean delivery, or maybe abortion, or maybe dilatation and curettage, there was some uterine scar right here, some myomectomy left a scar, then there would be, the placenta would tend to insert there. If there's a uterine tumor somewhere, then the space to get inserted would be decreased, and it would be inserted on the internal cervical os. And then what if there's multiple gestation? So multiple gestation, if one baby's placenta inserted here, other might be inserted here. So multiparity, increased maternal age, multiple gestation, uterine tumor, these are some risk factors. Talking about abruption placenta, previous abruption, maternal hypertension. Hypertension is very important in abruption placenta. It's a very prominent, very common risk factor of abruption placenta. Smoking, excessive alcohol, cocaine, smoking, alcohol, hypertension. This might lead to early separation of this placenta from the insertion of it on the uterus. And this separation, unfortunately, happens because of the bleeding at the decidual placental interface, and decidual is the maternal side. So the bleeding happens on the decidual phase, not on the chorion, but on the decidual interface of the placenta. Okay, so that would be because of maternal causes like hypertension, alcohol, smoking, cocaine, maternal age more than 35 years, or maybe premature, preterm rupture of membranes, rapid decompression of distended uterus. Uterus was distended, and there came a rapid decompression because of polyhydramnios or multiple gestation, uterine anomalies, or maybe any trauma. Trauma can also lead to placental abruption. In scenarios in QE1, most important thing to notice would be painful. And then we would see the bleeding would be painful. And then we'd see how much of the vaginal bleeding. Then we see the if there is any shock, anemia going on, and we'll see the vital signs. All right. Placenta previa implanted on the lower segment of the uterus, covering the internal cervical os. We just describe its relation with the internal os as millimeters away. It is painless, bright red vaginal bleeding, recurrent. Mean onset is 30 weeks. Onset depends on the degree of previa. This is to remember, do not perform digital vaginal exam until you rule out placenta previa. Because what if it is placenta previa and your digital vaginal exam would rupture the rest of it too? So speculum and transvaginal probes are safe, but the digital vaginal exam is contraindicated. Do not perform a vaginal exam until placenta previa has been ruled out by the ultrasound. And transvaginal ultrasound is the one which picks it up earlier. Yes, right here. Transvaginal ultrasound is more accurate. All right. So what would you see? You'd see a uterus which is soft, non-tender, because this is painless. Placenta previa is painless. Presenting fetal part can be high or displaced. Fetal heart rate might be normal. Shock or anemia would be there because there's apparent blood loss. And then in complication, there would be fetal mortality, prematurity, intrauterine hypoxia, which would lead to growth restriction, fetal malpresentation, premature rupture of membrane, fetal blood loss from placenta. And in maternal, the hemorrhage, there might be less than 1% chances of maternal mortality, hemorrhage, shock, anemia, renal failure, and then there might be a complication which is called as placenta accreta, especially if previous uterine surgery or anterior placenta previa. So placenta accreta is where the placenta just gets embedded within the endometrium. So placenta previa might cause placenta accreta and hysterectomy. You might have to take the whole uterus out. So investigations, transvaginal ultrasound. Okay, now this line. Spontaneously resolution is likely with increasing uterine distension if the placenta covers the internal os by less than 20 weeks at 20 weeks of 20 millimeters at 20 weeks of gestational age. So if you diagnose placenta previa at around 20 weeks of gestation before the third trimester, if you diagnose it, and if it is like pretty close to internal os by less than 20 millimeters, it covers the internal cervical os, then there are chances that it might resolve spontaneously on its own. Why? Because when the uterus is distending, when the uterus is growing, because the lower lobe of womb stretches more as the baby grows, the placenta usually moves on to the upper part of the womb by this point. 90% of the women who have a low-lying placenta at 20 weeks will not go on to have a low-lying placenta later in pregnancy, which is third trimester. So most of the ladies who tend to have low-lying placenta in their early trimesters, they do have some spontaneous resolution. Transvaginal ultrasound should be repeated in third trimester to make sure if it is there or was there a spontaneous resolution. How would you manage it? You would try to keep the pregnancy intrauterine as much as possible. You would try until the risk outweighs, of keeping the baby, until there is risk of preterm delivery. So you have to try to keep the pregnancy intrauterine, stabilize mommy, monitor them, stabilize by hydration, oxygen, monitor, do some blood works, get your blood ready. You might be needing blood at any time, cross match type, and be prepared for it. Look at the external fetal monitoring and continue ultrasound assessment. Just look at where how like determine fetal viability, gestational age, placental location. So you're stabilizing and trying to monitor, and give ROGAM to Rh negative mothers. So placenta previa, placenta abruption, wherever you see the bleeding, hemorrhage, there might be a chance of cross-reactivity of blood of fetus and maternal. So just go for ROGAM. We could also do Clear-Hor-Betke test, which is used to determine the extent of fetal-maternal transfusion, how much has it crossed. So you could also do that. So if it's less than 37 weeks, you'll go for expectant management, admit, limit physical activity. Less than 37 weeks, so we'll go for corticosteroids for fetal lung maturity, and deliver when fetus is mature. Or hemorrhage indicating maternal. If there is hemorrhage, you could see any fetal compromise or maternal compromise, then just go for delivery. But if it's more than 37 weeks, just go for cesarean delivery and deliver it. Less than 37 weeks, try keeping it within the mommy and try giving them corticosteroids. Placental abruption. The partial or total placental detachment that is premature, causing bleed on the decidual surface. It should be occurring after 20 weeks of gestation, because if it's less than 20 weeks of gestation, we'd call it as abortion. There is classification. It could be the total, partial, it could be external. So if this is the uterus and here's the placenta and the rest of the baby in the sac, of course this is the sac, okay, and suddenly there is painful vaginal bleeding, there are uterine contractions, patient comes into you with sudden localized lower back pain, sudden onset constant localized lower back and uterus pain, uterine contractions, uterine tenderness, and the vitals show that lady's going in shock. And you don't really see much of vaginal bleeding right here, but the blood pressure goes down to 90/60. There might be a huge chance that the placental abruption is internal and is concealed or occult. 20% cases. What happens is blood dissects upwards towards the fetus and may or may not present with vaginal bleeding. Or even if it does, the vaginal bleeding would not be enough to explain the amount of changes in the vitals, right? The changes in the vitals, the shock, the bradycardia, the apparent the symptoms of maternal compromise and fetal compromise would be out of proportion to the apparent blood loss, because it might be concealed inside, right? So make sure these two types: external revealed apparent and internal concealed occult. Okay. And then you can also see fetal distress, fetal demise, bloody amniotic fluid, coagulopathy. Then there are complications like mortality, prematurity, intrauterine hypoxia, then renal failure, anemia, hemorrhagic shock, pituitary necrosis, DIC. Placental abruption is the most common cause of DIC in pregnancy. So placental abruption, do remember that the abruption, the premature detachment, is the most common cause of DIC in pregnancy. And how do you investigate? It is pretty much a clinical diagnosis. Ultrasound is not really sensitive. You just stabilize the mommy, maternal stabilization, give IV fluids, oxygen, monitor them, send blood work, get ready with the blood products on your hand, red cells, platelets, cryoprecipitates, because if there is more DIC risk in here. and then do external fetal monitoring, keep on monitoring baby's heart rate and rest of the stuff. Start with ROGAM. You could do Hemorrhage test, which will help you know how much ROGAM you have to give. You'll give 300 micrograms, and then after that you would have to give, I believe, 30 for every milliliter. So 300 is sufficient for 30. I hope I don't forget it again. So 300 micrograms is sufficient for 30, and give additional 10 micrograms of ROGAM for every milliliter, 1 milliliter. So additional 10 micrograms for every 1 milliliter. 300 is for 30, additional 10 for every 1 milliliter over the 30 milliliter. Okay. So you'll do the Hemorrhage test, and you would know how much ROGAM you are supposed to give. So just give ROGAM. And then abruption could be without fetal or maternal compromise, which is mild, and it could be with fetal or maternal compromise. But if it is with fetal or maternal compromise, just hydrate, restore the blood loss, vaginal delivery or cesarean delivery. So if it is moderate to severe abruption, then we have to go for delivery. Just directly go for delivery and try to hydrate and restore the blood loss. Just try to save both of them. Cesarean delivery, if live fetus with fetal or maternal distress develops with fluid blood replacement, labor fails to progress, or vaginal delivery is contraindicated, go for cesarean delivery. But if there's like no compromise, it is mild abruption, then if it's less than 37 weeks, just like earlier, you try doing serial hematocrit to assess if it's concealed bleeding, and deliver whenever the fetus is mature. Give corticosteroids so that you can help the baby's lung mature. And if it's more than 37 weeks, just try to stabilize and deliver. So this is the formula. Less than 37 weeks, try to keep them inside and give them corticosteroids. But if the risk of compromise is outweighing the benefit of keeping them in, go for delivery. But if it's more than 37 weeks, just stabilize and deliver. Okay. One last differential of antepartum hemorrhage, which is Vasa previa. What happens in this one is the fetal vessels are unprotected, and they pass over the cervical os. This is the cervical os, and they pass over the cervical os, and these vessels are unprotected. These vessels had a filamentous insertion of cord into the membranes of placenta or the accessory lobe. What does this mean? So filamentous insertion means on the left side, sorry about that. On the left side in this picture, we could see that placenta, the cord is normally inserted into the placenta. But on the right side, we could see that the cord is not really inserted directly into the placenta. Rather, it's inserted on the membranes of placenta, or you could say on the membranes of amnion right here, and the blood vessels are pretty exposed. There is another really good picture for this. So this is the normal placenta. This is filamentous cord insertion. See how the umbilical cord inserts itself into the amniotic sac membrane or the placental membrane rather than directly inserting it into the placenta, right? So this is the normal insertion umbilical cord, but filamentous insertion umbilical cord is trying to insert in the membranes of placenta and not directly into the placenta. So what does it cause? It causes exposure of fetal blood vessels, which remain unprotected. And those unprotected fetal vessels tend to be more prone to lead to bleeding. So right here in the clinical features, we can see that the vaginal bleeding right here in Vasa previa would be painless vaginal bleeding, and the fetal distress. Talking about Vasa previa specifically, because these are the fetal vessels, right? These are fetal vessels which are exposed right on the cervical os. So the blood loss, whatever bleeding, vaginal bleeding, is happening because of vasa previa. In vasa previa, the bleeding is related to baby, and the blood is directly, more or less, the blood is directly coming from the baby. So in this case, baby is most prone to be having bradycardia or tachy to bradyarrhythmias, right? So in placenta abruptio, placenta previa, maternal compromise is there. Of course, fetal is there, but especially maternal compromise. But in vasa previa, because the blood, the bleeding is directly from the fetal vessels, then the fetal distress is very prominent. You can see a sinusoidal pattern on the non-stress test. In the fetal heart rate, there is a sinusoidal pattern. This is very typical for vasa previa. And there would be bradycardia. The baby's heart rate would be decreased because loss of blood, and there is mortality too. Okay. How would we investigate it? We do app test and right stain test. In app test, what we do is we mix the blood with sodium hydroxide. It can be done immediately, and what it does is it determines the source of bleeding. Whatever bleeding is coming, we'll just quickly mix and sodium hydroxide in it, and if it turns pink, then it is fetal blood, and if it turns yellow, then it is maternal blood. So it would help us know what's the source of blood, and if it's more fetal, then it is directly indicated towards vasa previa. And then we can also do right stain. What we do is we take a blood smear, we put the right stain on it, and we look for nucleated red blood cells. So nucleated red blood cells are abnormal. Normally we do not find them, but we do find them in many cases, out of which hypoxia is one. So we do find them in hypoxia. So in cord, we'll take some blood, not in the maternal blood. So in cord, we'll take some blood sample, make a blood smear, and put right stain, and that would show nucleated red blood cells. How would you manage vasa previa? Planned cesarean delivery 35 to 36 weeks, or if bleeding, then emergency cesarean delivery, since bleeding is from the fetus. That is why we see a fetal heart rate racing of sinusoidal pattern and bradycardia, because the bleeding is directly from the baby. Now we have a few questions from UWorld. Oh my god, I don't want to miss it. Okay. So page 173. Okay. This would pretty much summarize antepartum hemorrhage. 29 years old woman, gravida 3, para 2, comes to the emergency department due to sudden onset heavy vaginal bleeding that has soaked through her clothes. Oh my god, I didn't want to show the answer. Okay, sudden onset heavy vaginal bleeding and soaked through her clothes. Patient has had inconsistent prenatal care and says she is about 8 months. She has had some non-painful contractions. 4 years ago, she had a low transverse cesarean delivery. Just keep on looking on the hints. Just keep on looking on the risk factors. Patient smokes a pack of cigarettes a day and takes no medication. Temperature is this, blood pressure 96/70 because there was bleeding. So hypotension, pulse is 118, respiration 16. Fetal heart rate monitoring show a baseline of 150, moderate variability, accelerations, and no deaccelerations. Tocodynamometry shows irregular contractions every 10 to 15 minutes. How much was the gestational age? About 8 months. Okay. Which of the following is the most likely diagnosis? Now it is non-painful. So for me, placental abruption would be gone because it is usually painful. Preterm labor. How would I describe heavy vaginal bleeding with preterm labor? Nope. Uterine rupture. Okay, it might be the diagnosis, but in uterine rupture, you would see some other sort of indications. It would be painful, right? And the bleeding which is coming right through the vagina, soaked through her clothes, would be inside the abdomen where the uterine ruptured. The bleeding would be more on the inside. And then there would be tenderness, a lot of tenderness. And with the bleeding inside, the fetus also moves towards. So if this is the uterus, and over here we had a uterine rupture, so the fetus tends to gets in the abdominal cavity, and we can palpate fetal parts on the abdomen. And then there's a bulging sac on the in the cervix, which does not have any of the fetal parts. Fetus does not present down there. There's a bulging out there in the uterine rupture. And then Vasa previa, one thing Vasa previa would show bradycardia, and Vasa previa would show sinusoidal variability, not moderate variability, because there would be fetal issue, because the bleeding is directly from the fetus. And then this is non-painful. But over here in Vasa previa, we read it's painless, right? So it would be, yes, this is painless, Vasa previa and placenta previa. Both of the previas are painless. So, but these indications indicated that there is no fetal compromise, right? So I would pick placenta previa, right? Placenta previa is commonly diagnosed, covers the cervix, painless vaginal bleeding. Let's quickly read the causes. Why not uterine rupture? During the labor in patient, prior C-section with sudden onset vaginal delivery. However, patients also have intense abdominal pain, palpable fetal parts through the abdominal, and fetal heart rate abnormalities. In uterine rupture, there would be deaccelerations and bradycardia. In Vasa previa, fetal blood vessels that overlie the internal os, making them vulnerable to injury. Although patients with Vasa previa have painless vaginal bleeding, as in this patient, there is typical rapid deterioration of fetal heart rate racing, as the hemorrhage is primarily of fetal origin. So this is placenta previa. Blood loss is primarily maternal in origin, therefore fetal heart rate racing are typically reactive, which is normal early in the disease. So this was abruptio placenta, it detached. This is uterine rupture, palpable fetal parts. Right here is Vasa previa. These blood vessels which inserted, there was a filamentous insertion, and you could see the baby is turning blue too, because the blood loss is directly from the baby. But from now I remember this one is also painless. Both previas are painless. And then this is the normal placenta, and this is placenta previa, covering the overlapping the internal cervical os. Then I have one more question regarding placenta previa. Oh, placenta abruption. So in placental abruption, we read some complications right here. Renal failure, anemia, hemorrhagic shock, DIC. So DIC was one of the placental abruption, is the most common cause of DIC in pregnancy, and amniotic fluid embolus. So for that, I do have a scenario. Okay. 43 years old patient, gravida 6, para 5, 39 weeks gestation, has a brief generalized tonic-clonic seizure in the delivery room. She became disoriented, lightheaded, breathless, and cyanotic 20 minutes after an uncomplicated spontaneous vaginal delivery of a healthy neonate and placenta. Her pregnancy was uncomplicated. So basically, she just had a generalized tonic-clonic seizure in the delivery room, became disoriented, lightheaded, breathless, and cyanotic 20 minutes. But there was a spontaneous vaginal delivery. Baby was healthy, placenta was delivered, pregnancy was uncomplicated, no past medical history, blood pressure is 80/40. Pulse is 110, respiration 30. Oxygen saturation 75% on face mask, even on face mask. Examination shows an unconscious woman who is no longer seizing. A generalized purpuric rash and bleeding from the IV site. So, purpuric rash and bleeding from the IV site. Which of the following is most appropriate next step in management of this patient? Abdominal ultrasound, intramuscular magnesium sulfate, IV furosemide, IV heparin, intubation and mechanical ventilation. So, for this, the answer would be intubation and mechanical ventilation. Before getting into the reason why was this happening, what was the etiology behind it, we are gonna save the patient. And ABCDE says look for the airway first. And even on face mask, oxygen saturation is 75%. So we're gonna go intubate and mechanically ventilate this patient. What happened to her was an amniotic fluid embolism. It could be because of advanced maternal age, multigravidity, cesarean or instrumental delivery, placenta previa or abruption, preeclampsia. So in previa, it could be also there. How do you present cardiogenic shock, hypoxemic respiratory failure, DIC, disseminated intravascular coagulopathy, coma, or seizures? So this is the typical presentation of amniotic fluid embolism. They would present with seizures. So first of all, problems with respiratory problems, that is respiratory failure, shock, low blood pressure, high heart rate, DIC, generalized purpuric rash, bleeding from the IV line site. So this is the typical clinical presentation of amniotic fluid embolism. How would you treat them? Respiratory and hemodynamic support and transfuse them. This patient's presentation is concerning for respiratory failure from amniotic fluid embolism syndrome. It is rare, but it is catastrophic. It could be because of these risk factors, which we already read. Amniotic fluid embolism syndrome is diagnosed clinically after excluding other causes of sudden postpartum cardiorespiratory. So this is happening. Baby was delivered normal. 20 minutes later, there was sudden postpartum cardiorespiratory failure. So you have to rule out other causes first, which could be eclampsia, peripartum cardiomyopathy, pulmonary embolism. Treatment is mainly supportive to control the hypoxemia. You just go for oxygen, intubation, mechanical ventilation, and you have to control the hypotension by vasopressors. Early recognition with respiratory and hemodynamic support can reduce maternal and fetal mortality, but survivals have still an incidence of neurological damage. So why don't we go for ultrasound? Because it can assess the bleeding, which can be due to uterine rupture in multipare patients such as this, although massive hemorrhage can cause hypotensive shock. This patient's rapid respiratory decompensation requires intubation for ventilatory support before performing ultrasound. So we have to save them first before performing ultrasound. Why not IM or IV magnesium? That could prevent and treat eclamptic seizures. Although eclampsia can cause seizures in pregnancy, patients usually have hypertension. This patient had significant hypotension, which makes eclampsia less likely. In addition, magnesium would further lower down the blood pressure, so we cannot even think about magnesium. I know that first thing with the tonic-clonic seizures we have in mind is magnesium, but that would further lower down the blood pressure. Furosemide can treat pulmonary edema and improve hypoxia due to fluid overload. Although pulmonary edema does commonly occur with amniotic fluid embolism syndrome, pulmonary edema does occur, but this patient's respiratory failure requires initial intubation and mechanical ventilation before any further treatment. And why don't we use the option IV heparin? Heparin anticoagulation is generally indicated for pulmonary thromboembolism, which can cause acute cardiopulmonary failure. However, this patient's purpuric rash is concerning for DIC. Heparin should be administered in a patient with a significant bleeding or signs of platelet dysfunction. This patient's failing respiratory status must be managed first. So, what is the educational objective? Amniotic fluid embolism syndrome typically presents with the rapid onset of respiratory failure, severe hypotension, and DIC. during labor or immediate postpartum period. So, this is how amniotic fluid embolism syndrome typically presents. The amniotic fluid embolus might have dislodged and it can cause severe hypotension, respiratory failure, and DIC. It could be during labor or it could be immediately postpartum. The diagnosis is made clinically and management is supportive. Amniotic fluid embolism syndrome is rare, unpredictable, and is associated with um, maternal and poor maternal and fetal outcome. This is it for the antepartum hemorrhage.